right, everyone. Thank you so much for dragging yourselves back inside. It is so gorgeous outside, but I promise you it's going to be well worth your while. I would say they saved the best for last, except everything's been wonderful, so you're getting more wonderful at the end of our first day. So I'm first of all going to introduce Dr. Peter Stilwell. Oh, Richard? Okay, thank you. I'm going to first introduce Dr. Peter Stilwell. He's a postdoctoral researcher at McGill University in the School of Physical and Occupational Therapy. He is the past Ronald Melzack Fellow in Chronic Pain Research at the Allen Edwards Center for Research on Pain. Most of his research is focused on the topics of pain, suffering, and person-centered care. So please welcome Dr. Stilwell.
All right. So I see some margaritas flowing, which is going to make this a bit more tolerable. At least my part of it. But yeah, it's such an honor to be here, to be able to co-present with Dr. Walumbe. Really excited, appreciate this opportunity. So let's get right into it. So our main objective today is going to be to get you to reflect on some of your assumptions about pain, and we're also going to introduce you to some contemporary pain theory. So I'm going to start by doing about a 20-minute presentation. I'm going to talk about pain theory, specifically something called an enactive approach to pain. And then Dr. Walumbe is going to talk about the multiple realities of pain. Then we're going to have some discussions, and there's also going to be a break built in there as well. So we're just going to have these initial really short presentations, so we ask you just to hold your questions until we're done. And we really encourage you to use those notepads, write down your questions, write down your thoughts, because we're going to get you to explore some of that stuff in groups when we start to break up. So yeah, pain theory, a Friday evening, maybe not the most exciting topic, but it is really important. And I think this is really nicely highlighted by Anjum et al. So they say that no practice takes place in a philosophical vacuum, and medicine is no exception. Health sciences and healthcare practice are enabled, shaped, and restricted by tacit philosophical assumptions, which practitioners should be aware. So really what this is getting at is that everyone has beliefs and working understandings of pain, whether they realize it or not, and whether they actually put a label on these things or not. This is essential, this is really important, because these understandings shape the way that we assess pain, shapes the way that we explain pain, but also shapes the management of pain. So it wouldn't be a presentation without this image from Descartes. So I'm going to go briefly through some pain theories, really prominent pain theories that have been influential. So starting with Descartes in the 17th century. So he had this very kind of like linear perspective in a lot of his writings. So you stimulate the peripheral tissues, you have a direct line going up to the brain, you experience pain. He then threw a wrench in things as well, suggested this dualism where you have this mind and body separation. And I'm going to return to that shortly. Then Melzack and Wall said, not so fast. It's not just a simple linear path up to the brain. We can actually have modulation at the level of the spinal cord. So danger signals or these nociceptive signals can be modulated at the spinal cord. I think most of you have heard about this theory. And they also argued that the brain isn't just some sort of passive organ. It can actually exert anti-nociceptive effects, so it can actually modulate those signals as well. This led to a lot of excitement about the brain. People saying, well, pain is all in the brain, it's ultimately in the brain. We need to study the brain to really better understand pain. And then more contemporary theories saying, well, maybe we need to consider it all. Tissue damage, if it's there, the spinal cord, the brain, but also a person's broader social context. And that's largely where the biopsychosocial model of pain is situated. And as most of you know, it's gaining a lot of popularity. So George Engel introduced the biopsychosocial model in 1977, and really it just started with his dissatisfaction with the biomedical model. So we were talking about that already this morning. So Engel said it was reductionist, this biomedical model. It was taking really complex health conditions and inappropriately reducing them to just biology. He also argued it's often dualist, so it's separated mind and body, so still holding on to some of those ideas from Descartes. So he was frustrated because he felt that that current biomedical paradigm didn't really leave room for the psychological and social aspects of illness. So he proposed his biopsychosocial model, which really emphasized the importance of clinician-patient interaction, and of course the need to consider bio, psycho, and social factors in what he thought should be incorporated in every healthcare task. So we've seen a lot of application of the biopsychosocial model in the field of pain. And during my PhD, I was like, is this really, though, adequate to understand pain? So some of my work that I was a part of started to actually provide some critiques of the biopsychosocial model. So when we really start to look closely, you look at the landmark paper in 1977, there's this kind of like short and vague paragraph suggesting that systems are linked. He expanded on this in his 1980 paper, suggesting that information flows somehow across this vertical hierarchy pictured on the right here. And I think this is a really, really good start. So we're not saying the biopsychosocial model is no good, but some of us have argued that it doesn't really help us better understand perception, doesn't really help us understand that subjective experience of pain. In a lot of our work, we also argued that there's these kind of like misapplications, potentially due to that vague underlying theory. And these misapplications seem to conflict with what Engel was trying to get us moving towards. So I'm just going to briefly go through some of those misapplications that we and others have proposed. And I think Michael already highlighted this one this morning. So the biopsychosocial model has been biomedicalized. So a lot of people will say, yes, let's take this holistic approach, but we're still placing primacy on the biology. Many approaches still trying to objectify a subjective experience like pain. Relatedly, we also see something that's been called neurocentrism. So we want to take a comprehensive approach, but sometimes we get a little maybe too excited about the brain, trying to reduce pain to just neural activity, brain activity. And so what some of us have argued is that the more we focus on the brain, the narrower kind of view that we have, we may actually start to trivialize or potentially even overlook important factors like social factors, culture, that was already nicely highlighted earlier today. The biopsychosocial model has also been fragmented. So we've seen this classically with the separation of body and mind. So people, if we can't find the source of pain in the body, people say, well, it must be all in the mind. Unfortunately, though, as most of you know here, especially if you have lived experience with pain, this has led to a lot of stigmatization. So a lot of people have been arguing, well, maybe we need to move beyond the biopsychosocial model, and potentially this enactive theory, enactivism, or the enactive approach is one way that might help us move a bit forward. So enactivism is a rapidly evolving theory for experience. It was formally proposed in 1991 in this book, The Embodied Mind. And since then, there's been a lot of different applications in various fields, and only recently applications in the field of pain. So what I think is particularly interesting is that a lot of recent enactive developments have explicitly been trying to target gaps and limitations in the biopsychosocial model, so trying to strengthen it. And what's attractive to me is it has this really rich theoretical and empirical foundation to draw from. So although it was only proposed in 1991, it builds on over a century of theory, very rich theory that potentially can be harnessed. So we and others have been arguing that maybe this could help strengthen and potentially even modernize the biopsychosocial model and maybe help mitigate some of those misapplications that I just introduced. So I'm going to dive a little bit deeper into enactivism. Take this with a grain of salt, though. There's been thousands of papers on the topic. There's books on enactivism, like the ones on the slide here. So I'm just going to be just scratching the surface. So keep that in mind as I continue here. So what is enactivism? So enactivists typically argue for an integrative framework for experience. So right off the bat, they say, hey, we're not splitting things up. It's not like we have the body on one side, the mind on the other. Rather, we're appreciating the whole embodied person and how interactions in the environment enact or bring forth experiences of ourselves, but also our experiences of the world. So a lot of enactivists will say pain is not just simply caused by the brain or in the brain. We can't reduce pain to just neural processes in isolation from non-neural processes, from interaction in an environment, in a context. So what I think is interesting is enactivists take this very kind of like simple, I think, but quite a surprisingly underused alternative. So it's always the person, of course, with a brain and a body in a certain context who experiences pain. And many factors are always shaping that experience. Therefore, we must consider the whole person and their unique history and context to better understand and manage pain. So we're not splitting it up into these different domains. Instead, we're striving to consider the whole person in interaction with their unique context. So that was kind of broad strokes, giving you a little bit of a flavor of enactivism. But I think we can dive a little bit deeper into something called 4E cognition. So that's something that enactivists typically rely on in terms of theory to express some of the more nuanced aspects of enactivism. So the 4Es, there's things that start with E. So the idea is that the experience is embodied, embedded, extended, and enacted. So what I'm going to do, I'm going to briefly go through each of the E's, and I'm going to give some kind of various examples to kind of illustrate them, but also some applications to pain. So first E, experience is embodied. So the idea here is that experience depends directly on the body as a functional whole, not just the brain. So we experience ourselves and the world with, through, and because of our bodies. So the idea here, the mind is not separate from the body. So the state of our body, the way that we move, shapes our experiences. Lots of kind of interesting empirical studies in this area, for example, showing that distances might look longer when we're fatigued, like actually look longer. And hills can appear steeper when weight, for example, a heavy backpack, is added to our body. So I think studies like this are interesting because they can provide some insight into the perceptual uniqueness of each individual, how each individual is different. I think we could start to speculate on how this might actually relate to something like low back pain. So what might look like a small hill to one person could look like a steep mountain to a person living with pain. So a lot of people ask, well, why would we experience the world in such variable ways? So wouldn't it be better just to see the world as it really is, just seeing physical properties in the same way as everybody else? Well, the answer might be simple. This is just speculation, but perceptual variability might allow us to flexibly act in a world in ways that are sensitive to our bodily states, but also our contextual circumstances. So the idea here is that perception is for action. It guides what actions we pursue. And this is fortunately, an adaptive process. But consider again those studies that I talked about. So when we're weighed down or fatigued, viewing distances as longer or hills as steeper can actually make them seem less walkable or less climbable. And this could be helpful. This could help us, prompt us to rest and conserve energy, which is adaptive. But areas where we start to run into some trouble is examples like persistent pain. So a lot of enactivists have been arguing, well, maybe we can become stuck viewing ourselves and our world in certain ways that might not be that adaptive anymore. But there may be good reasons why, contextual reasons, why we can get stuck. So if you're interested in more about that specific topic, this paper led by Dr. Konings, Sabrina Konings, is available open access if anybody's interested in that. The next E is that experience is embedded. So the idea here is that experience is shaped by the environment that a person is embedded in. So this environment is physical, it's sociocultural, it's political. So simply put, our context shapes our experience. So simple examples here that you're probably familiar with. Consider the athlete's experience of pain at a busy sporting stadium versus home, isolated, alone. Likely different experiences. This theory has also informed environmental interventions to intentionally shape how people act and feel. This is a really funny one, an enactive art installation. They created a room where you couldn't actually physically sit. Why you'd want to do that, I don't know. But it gives an example, shaping the environment. Fortunately, there's cheaper ways that we can shape the environment. So for example, VR technologies to help people with pain maybe view their body and their world in new and positive ways. I'm sure Dr. Stanton's going to talk about this stuff in her presentation. And some enactivists have been working in this area using enactive theory to guide their VR intervention. So that work's hopefully coming out soon. So as the E's progress, they get a little bit more radical. So the next one is experience is extended. So this is the idea that the environment not only scaffolds or supports cognition, it can actually be a part of cognition. So really simple example, consider the phone that most of you folks have in your pockets. So in a way, we actually treat them as like an external source of memory. So we don't memorize phone numbers anymore. We offload them into our phones. So if you took away my phone, I would lose the ability to achieve certain cognitive tasks, like call a friend. But folks in the enactive literature say we can take that even further and make ethical arguments regarding this theory. So consider the person with dementia. Often these folks will use Post-it notes, journals, different cues in their environment so they can navigate daily life. And there's some evidence that if you take that person, put them in a care home, take away those cues, you could radically change their cognitive capacities. You could change their sense of self, who they are. This is a lot of speculative stuff, but I think we could apply these ideas to pain management and rehabilitation quite broadly. So consider the use of canes, prosthetics. They can become a part of a person. So we have to be careful with how we touch, how we navigate those non-biological items. And I think many of you folks working in the rehab area already know this. But it doesn't stop there. So enactivists say it's not just about the material items, it's also about how political and legal processes can constrain and enable how we think, act, and feel. So the example brought up this morning, I already had it in my slides. I was like, yes, third-party payers, an example there. Often looking for a tissue-based explanation for pain can be extremely frustrated from the person that doesn't have some fancy diagnosis or something that we can clearly pinpoint. So it clearly can shape how people feel. So the last E that I'm going to talk about is that experience is enacted. So this brings together all the previous E's. So the idea is that through being embodied, embedded, sometimes extended, we enact or bring forth our unique experiences of ourselves and the world. So we kind of use this funny analogy in one of our papers about how pain is like a bird's flight to get at this kind of abstract idea. So bear with me for a second. So first we can consider flight. So if we want to better appreciate flight, we can't only just do some investigation into the feathers, into the wings. We're not going to find flight in the wings. Instead, we need to zoom out. We need to consider the whole bird. We need to zoom out even further and consider the bird's interaction with the atmosphere. And together, through all these dynamically interacting factors, we might be able to better appreciate what flight's all about. But I think we can say the same or similar type of thing about pain. So we're not going to find it by just looking into the bodily tissues. It's the wrong place to look for pain. We need to zoom out a bit, consider the whole person, crucially listening to their narratives. Zooming out even further to consider their context, interaction with their environment. If we're bringing all these things to light, we can maybe get a little bit closer to appreciating that experience. So the idea here is that if we take these E's, this enactive theory, quite seriously, it might actually help us avoid some of those biopsychosocial model misapplications that I previously introduced. So overall, enactivism compels us to look at this whole picture, the relation between person and environment. I think the field of pain has been really good at zooming in on the body, on the individual, but we also need to zoom out. So enactivists often kind of flippantly use this quote from May's 1977, ask not what's inside your head, but what your head's inside of. I think this quote's also fitting. When a flower doesn't bloom, you fix the environment in which it grows, not the flower. I think there is some truth to that. We've, as a field, often been trying to focus on the individual, and the more we do that, we overlook possibly nurturing the environment. So really short conclusion here. So theory matters. I think you got that point. Enactivism, I wouldn't take it, hold it too closely, but it's just one theory that could potentially help us strengthen and extend the biopsychosocial model, can be combined with other theories. And what I think is interesting is it's probably already a framework for what you already do. A lot of it, you probably already recognize a lot of these things. You're like, oh, that makes sense. But I think if we actually harness the theory, including some of the nuances that I didn't get to present on today, we may actually be able to strengthen our approach, do things with more intention, and like I said, avoid those misapplications. So if you want to learn more about this, I'm around for the weekend. Feel free to reach out. We've published a variety of papers on this topic. I'm happy to direct you if you're interested, and we'll leave it at that. Thank you.
Thank you very much, Dr. Stilwell. I'm sure there will be questions, but not until the end. So now I'm going to slowly and dramatically introduce Dr. Jackie Walumbe, because there's some tech things that have to happen. Okay, so Jackie is just going to say some stuff. No, I'm kidding. We talked about how much of her bio to read. So Jackie is an advanced practice physiotherapist at University College London Hospital's NHS Trust in London, UK. Jackie works with multidisciplinary teams and is involved in the management of complex pain in an integrated system across specialties, as well as primary, community, secondary, and tertiary care. She's a postdoctoral fellow looking at medicines and pain with health equity focus. Is that right? Close?
So good.
This is Jackie.
Hi, everyone, and thank you so much for introducing me so wonderfully. I am going to stand behind this huge lectern. I hope you can see some of me, mainly because I do want to do this justice, and thanking Dr. Stilwell for doing such an eloquent introduction to what is a deeply complex literature and theoretical framework. So moving on into this kind of second half of our conversation, as we're calling it, we've put up some questions for you to hold in your mind as I go through this kind of second part of the chat, and we will come back to these questions. So the title of our whole symposium or workshop was, what is your philosophy of pain? Now, that might mean a little bit more to you now that you've heard Dr. Stilwell give us an introduction of one philosophical standpoint. But these are a few other questions for you to hold in mind as I go through my conversation. So that is me and all the funders. The work I'm presenting today was funded by the National Institute of Health Research. This has nothing, they do not support my views, etc., etc., disclaimer. And I am employed by the National Health Service, which is a universal healthcare funder in the UK. And I did my Ph.D, which is what DPhil stands for at the University of Oxford. So just to give you a sense of where this story is coming from. So I begin with this quote, it's drawn from the book Things Fall Apart. Some of you might have heard of it, by the Nigerian author Chinua Achebe. And he says that there is no story that is not true. The world has no end, and what is good amongst one people is an abomination amongst others or with others. So this is kind of the thing I want you to hold in your mind lightly as I go through this, as we move swiftly and try and think a little bit more about pain. So this book by Berger and Luckman is fairly old, but it's called The Social Construction of Reality and is considered a really big tome in the world of sociology, where they argue and they present their thesis that how can reality be known? So we've talked a little bit about different forms of reality, but they were really concerned with how, from an external perspective, how can we know what someone else's reality is? They also argue that reality is socially constructed, meaning that people shape their experiences through social interaction. So a lot of what we have already heard of before. And so thinking about pain, and if we consider the idea that perhaps pain might itself be socially constructed, pain is inherently multiple because it cannot be one thing if it is socially constructed. If it's not a single concern, condition, or category, there's something different for us to think with if we hold that idea in our minds. So pain is experienced differently by different people, and its meaning and expression cannot be stripped of context, power relations, and history. And that's taken from Burke and their book on the culture of pain. Nope, something else entirely. So I am thinking through, and I want you to follow through with me about, okay, if we hold the idea that pain could be multiple, where do we see examples of this multiple ideas of pain? And I start with something that should be quite familiar to everyone in this room. Any shouters as to what this is from? Okay. Oh, go on. Absolutely. So this is the International Association for the Study of Pain 2020 definition of what is pain. Now, this was arrived at by consensus of a very, very, very large body of people, scientists, clinicians, people with lived experience, and this is what they came up with. So spot what could possibly multiple about this. Pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage, right? So there's a lot in that statement. And that's not the entire definition because there are, of course, 6 additional keynotes that we're supposed to hold when we think about what is this thing called pain. So they argue pain is always personal experience, influenced by biological, psychosocial, and social factors. Pain and nociception are different experiences, notes, etc., etc., etc. The thing about this definition is that though we accept that a person's report of pain as an experience should be respected, we continue also in the same community to lean towards things that make pain a little bit more singular. So the drive towards quantifying pain, pain intensity, pain interference, pain catastrophizing, pain self-efficacy, right? So we're always trying to recategorize this big, messy thing that is called pain. And perhaps this pull to quantify and generalize is impeding some of our efforts to work with people who are experiencing pain. For when someone presents in front of you or in your research lab, you could ask, which pain is being managed if there's so much going on? And we're faced with quite a lot of these myths and debates, either on social media or in our clinical practice. So is it acute or chronic or subacute? Is it chronic or is it persistent? Is it neuropathic? Is it nociplastic? Is it biological, psychological, social, etc., etc., etc.? So I propose here that perhaps there's a different way of thinking through some of this complexity. So for my PhD, I sought a philosophical approach that allowed for thinking with multiples rather than with a singular idea. So I was thinking conceptually about addition, so and, rather than either or kind of frameworks. And I fell on this idea of multiple ontologies, and apologies because I'm now going to use the word ontologies throughout the rest of my talk. By that, I just mean realities. You know, what different realities of pain are there for the shorthand? For those of you who are more versed in ontology, that's what I mean as well. So Scott Graham wrote a book in 2015 called The Politics of Pain, which is an extremely interesting book. And it was a report on the ethnography he did of something called Midwest Pain Group. And in terms of his understanding of multiple ontologies, he states that this describes differently situated material activities that produce different kinds of objects, saying that the reality you engage in is determined by the kinds of actions that you habitually perform and the material context in which you act. So this kind of conversation about context, environment, objects being important is coming through as well. And he draws very strongly from the work of Anne-Marie Moll, who extols that reality is something that is done. It's not something that's only perceived in our minds. It's something that is enacted, using Dr. Stilwell's words there. She goes on to say that reality is constructed through doings or practices, and doings can take many forms and iterations. So again, allowing so much more space for this idea of multiple ontologies. So for my empirical work, I used qualitative methodologies. I focused on instances of where my participants' practices, so what they were doing and their performances of pain management, was the lens through which I was looking through multiple ontologies. Now, this was specifically, I looked for ways that people narrated their practice and how I observed and interpreted that whole scenario. So the data I report here is drawn from health and social care providers and not people with declared lived experience of pain, as that typically affects where care and what care is offered to people living with pain. And I focus on illustrations that indicate something called ontological conflict. So where these realities are kind of clashing, and how does that present itself in terms of uncertainty. So in Graham's book, he identified 6 different ontologies, and I extended his work by identifying within my data different kind of pain ontologies. I will go through each, and I will give you an example from my data. So the first one is the semiotic or biomedical traditional ontology. So this is very much that pain is a sign signifying underlying disease. It aids diagnosis and prognosis. Pain equals damage. It's reliable. It's proportional. So that's something we're all very familiar with. It works better for acute presentations than for other kind of presentations. And I have a whole quote here, but I'm going to read only a section of it. This is from a general practitioner or a primary care physician, and all the other words that you use in your different places. So this person goes on to talk about how fibromyalgia, like we heard about earlier today, this person's not buying it. It's like fibromyalgia, I just can't, I'm not getting my head around it. And goes on to say, yeah, there may be a subsection of people with chronic pain who are actually suffering from non-diagnosed disease, which, if it was found, could be treated. So this person is really holding quite strongly to, even in the absence of demonstrable tissue pathology, if I look hard enough, these people have been misdiagnosed. That was their concern. So what we're kind of seeing there is, that is a very traditional model. And so Graham goes on to say that there's, even within biomedical, we tend to talk about biomedical issues. So even within biomedical, there's this kind of split, because there's this now biochemical ontology, that pain is this biochemical entity. In this kind of practice or ontology, pain is objectified. It is the object of study. We've already heard about, this neurocentrism, or other people have called it the neuron doctrine. We focus on neural pathways of of transmission. Pain is mostly about nociception, neural encoding, and the focus of treatment is usually pharmacological. So the target is pharmacological. And this aligns with conditions which have known biological processes such as inflammation, things like rheumatoid arthritis, for example. And for this, I will use the quote on the top. So this is, again, another general practitioner talking about a patient. So the patient I was talking about before, I specifically wrote a couple of times to the pain clinic, very much asking whether they would address some of the psychological issues around her pain. And all they did was promise her another facet joint injection. So that was quite frustrating, and she'd waiting for months and months for that. That, in my experience, is not a unique experience. Right? So in this kind of piece of data, we're looking and seeing ontological conflict where someone is sending a referral on and hoping for one outcome and receiving something entirely different. Moving on. So Graham then talks about, okay, now there's another kind of pain that's out there in the data, and he called it the empirical discursive ontology. So this is still, again, within biomedical. It's still thinking biomedically, but we've moved on from some of the traditional notions. We are now modern. We're with the contemporary. And this is a statistical account of pain. So we will be very familiar with this kind of ontology and where it shows up in practice and in research. So things like evidence-based medicine, these statistical accounts of like brain imaging, things about standardization, making pain objective, let's turn it into a number. It's visible, it is disciplined, it can be structured. We know pain in this way through observation and experiment. And so highly biased towards a medical gaze. And we extend that to even when we think about psychological construct, it's through brain neuroimaging, which is essentially a big, I think, statistical endeavor. So this, again, is better on a population level, for example, clinical trials that give us some really good information about things like drugs. They fall short when we are dealing with more complexity. So this appeal for randomization, of course, removes noise. It removes confounders. It is thin on context. So we're starting to see a little bit more going on here. And this little ditty, I call it. It's quite long, but it is essentially a pain consultant explaining how they manage someone with opioid dependence. And they're saying, what we do is at the end of the consultation, we will have worked with them to show them that their dose of opioids is much higher than recommended maximum. We have a calculator on a computer. We look at what they're taking. We put it on the computer. We show them. We say, it's a high number, which helps. Then we take them through a template, and et cetera, et cetera. So this person is committed to a statistical understanding of opioids and perhaps, therefore, of pain. So we're moving on a little bit now. And I would then, Graham again, in his data, identified a cognitive behavioral ontology. And note, I do not say psychological. He named it cognitive behavioral. So this deals a little bit with the psychological impact of pain, a changing relationship with pain, ideas around coping, living well, and again, is embedded with practices of standardization. So we give people questionnaires, they come back, and we look at effect sizes and things like that. So it is aligned very commonly with specialist services in the UK, at least, and this seems to be the case for Graham's data in the Midwest of America. And I draw again on the top quote of a pain consultant saying, using the language of this cognitive behavioral ontology. So one of the problems with, or one of the advantages, I think, actually, at the inpatient pain team is that we can come into a ward where they may have a destructive, challenging patient who is using pain as part of their other challenging behavior, and we can almost protect the ward staff by coming in, giving them a plan, maybe having a difficult conversation, again, moving towards opioids, safety, etc., etc. And there were multiple of instances of this kind of ontology or reality in the data. And so you might be asking, where does my stuff sit? I don't practice like that. I'm really cool and on it. So yes, these people were not left behind as well. So Graham identified what he called a non-modern practical ontology. And for those of you who are sociologically minded, he akins this to postmodern thinking, so like more than modern, so non-modern, which I'm sticking to his kind of language. So this is multi-professional, multidisciplinary, working across boundaries. He uses the phrase calibrating practices, so working like really in an entwined way for the benefit of the patient. And this is practical applications of the biopsychosocial model. I did not find evidence of this in my data at all. So I didn't see any practical applications of this kind of ontology, though I am aware of it outside of a research perspective. So from an autoethnographic account, I'm like, okay, maybe it exists. But what Graham also identified was a non-modern discursive ontology, which is where we talk about doing that boundary work. So we're multidisciplinary, we're working together, but it's more in our language rather than in our actual practices. And this is pain management theory that we've heard about, drawing quite heavily on narratives, patient-centered care, ideas, personalized care. And this was present in patient-facing materials, almost in an idealistic form or a bit of rhetoric. It was almost like trying to convince people that this thing exists. And I'm going to move on. So the other two ontologies that I picked up on in my data were biomechanical and the embodied intersubjective, because according to Graham, this was not like there's 6 of them and we're done now. This will be something that's continually changing and in flux. Now, in a room full of people who might have had training in biomechanics, this was really present for me. So for me, it was in the data, it showed up where participants had let go or stopped practicing in this really familiar way. So this is anatomical ideas of the body as machine, and the practice is related to fixing the broken machine. It's a keystone in physical therapies, and it was drawn for me mainly from the fact that I am a physiotherapist and I have lived it, but also critical literature that's emerging, that's starting to challenge this way of thinking about pain as separate from more specific biomedical ideas. Biomechanical emerged as something very different. And I should say that in practice, this was, these ideas of motion is lotion. You can't go wrong. That's the one. Being strong. So they're very embedded within these notions of practice. So this physiotherapist goes on to say that not trying to fix everything all in one go and not trying to fix anything sometimes, I felt that helped me relieve the pressure off me, because I guess I felt I'd been trained to fix people. All right, so this practice related to fixing a broken machine. But there was something else, and this is probably a little bit more like what Peter was talking about, that we named the embodied intersubjective completely independently. We didn't concur. This was done at different times. So it's an ontology that was very different from all the others, because in practice, it focused on holding uncertainty. It was not diagnosis or meaning focused. It wasn't always leaping to the what is going on here, what could this be about. It was clinicians showing that they were comfortable with mysteries and doubts, they were open, they were movable. It was happening outside thought silos, so not in pain clinics at all, but this was in professional groups like social prescribers. So in the UK, this is a group who support general practice and primary care in getting people to do more in their communities. It was also really present with policymakers, so people who had perhaps been disillusioned as practitioners and had moved on to make healthcare policy. So this was, again, a slightly more hopeful kind of ontology, I think. And I think a lot of people are very open to thinking about the impact that some of the social factors as well have some sorts of life stresses and how that exacerbates pain, poverty and the challenges of trying to deal with the issues around that. So in practice, they're saying I have to think about those wider issues that are coming into my consultation. I cannot ignore them. and I will not read that one out, but it's essentially a really nice quote of a GP encountering a patient out in the wild and this person giving them a massive hug, not because they had necessarily solved their problem, because there was something more relational that had been built into their thinking about the pain problem that remained very, very much present. And so Moll cautioned against discarding signs that were incompatible with any particular ontology, and she argued instead for addition as a powerful way of creating singularity. So moving away from seeking meaning and towards generating action. So what can we do about it rather than always sitting in this position of tension? And the addition of these accounts uncovers an embodied action, again, this by doing through something that is happening in the world, that is relational, it is intersubjective, it's open and bears witness and supports. And this embodied and intersubjective ontology generates these hotspots or liminal spaces where multiple ontologies can coexist and articulate and form, and from whichever different and alternative ways of doing can all kind of be there together. And the one example I found in my data was from an occupational therapist who was pretty happy with whatever was present. They were very focused on, yes, they had a professional identity, but they were very much like, if you look through medical eyes, you might miss something, and therefore they hold quite a lot going on. And so just to start to summarize and think through here, that for me in my data, dualism clearly persists. There's still this mind-body split in how people were practicing. And for me, I started to ask the question of what happens, and this is a question for you as well, when there's little agreement, what happens in that space? And Kuhn and Feyerabend, both independently of each other in 1962, talked about the incommensurability problem, where competing paradigms, theories, ideas, life worlds, they lack a common measure language because they use different concepts and methods to address these different problems. And so we see kind of professional groups taking part in this activity to protect the jurisdiction. They create new categories to try and resolve what it is that they're trying to do. Some examples there of psychosomatic as an idea that maybe we can talk together if we create a new category, or different functional disorders. Things like psychologically informed physiotherapy, how do we stick a bit of this into that? And for me, and my thesis was on self-management. And I end by kind of saying that in my data, the presence of ontological conflict was linked with what is identified in the data as moral injury. As practitioners were really struggling with holding all these kind of multiple perspectives, which were often in conflict with the systems within which they worked. And this paramedic was just really open and honest about saying, perhaps I need to find a way to resolve some of these really contested and difficult conditions. And the consultant here says that, thinking about if they understand where patients are coming from, because if medicine can do so much, why can't you fix my pain? And they're starting to think, okay, perhaps this is something that I need to think differently about. And I conclude by proposing that by raising awareness of these ideas of multiple ontologies or multiple realities of pain might enable healthcare professionals and practitioners to develop their own repertoire of practices in a way which might be more inclusive, and that may limit the epistemic injustice that we heard about this morning from Gilletta that have typically dominated chronic pain care to date. And what more can we do if we think with an and perspective rather than an either or? And I'd just like to finish by thanking all these people and come back to these questions and stop talking and say that you've got about 20 minutes. Is that right, Peter? You've got 20 minutes, so it's an invitation. Again, it's not compulsory, and I hope we have presented, there's no right or wrong way of thinking about this. It's just thinking with philosophy or from a philosophical standpoint can open up different ways of thinking outside our traditional kind of roles and boundaries. So amongst your tables, perhaps have a really extended discussion for between 20 and 30 minutes. and Peter and I will wander around and eavesdrop, and then we will come back and we will pull all of this together somehow without resolving it. Thanks. Hi, everybody. Oh, it's my karaoke moment. Hello. Just keep talking. Hi. Great. This is very unusual. I don't know where to hold the microphone. Can you all hear me? Great. So that was it sounded really interesting. Lots of generative ideas, discussions, debates, etc. So what we thought might be helpful as a way of perhaps hearing from everyone in the room was, as you have been mostly in a stable environment and a table, if perhaps a representative from each table wanted to maybe capture a flavor of the discussion and maybe summarize, any kind of things that stuck out for you, any questions, but from a table perspective. So we're asking you to be a collective, if that sounds all right. And if you didn't talk about it, that's also fine. We would like to hear all Margarita-induced chat as well. So any kind of volunteers, any itching thoughts desperate to go first? Brilliant. So what I'm going to ask you to do, if that feels okay, is if you can approach the microphone that is set up in front of you, and let us know.
So the one brief thing I want to say is that you touched on non-modern practical, and I agree there's not enough research, and yet that's the vast majority of what my career time has been, and that's the vast majority of what I focus on when I teach classes. So it's extremely frustrating for me to hear that that's the least researched, least well understood thing in terms of like what you were able to address in your talk, because that is 95% of what I do that I find useful.
Great, thank you. And I think that was a challenge for me as well, because this is the narrative, right? We are all biopsychosocial now, and looking for regimes or practical ways that this was being enacted. And this perhaps would have been my data set. Maybe that's just what was happening at the time. But I should also declare, so I work in probably, I think it's the biggest multidisciplinary pain center in the UK for one. We've got over 100 clinicians working across, it's multidisciplinary. We've got psychologists, they're everywhere. We've got physios, we've got medics, and we're supposedly working through a biopsychosocial lens, but in practice, I certainly see more boundary work than I see that true enactment of biopsychosocial. So, yeah, a good reflection. Who wants to? Yes, I love this.
Hello. I would like to say that our group went and talked about complexity, and that I had to Google the word ontology because I didn't know what it was. And I probably have done that 10 times in my life. Like, it just doesn't seem to stick, but the talk made sense, but it underlies how complex it is, but that we have to use embodiment in a full body and contextual approach, which makes it even more complex. I just am going through a word spiral now.
So good. You said all the words.
I love to hear that, the complexity, right? Any other groups talk about how navigating that complexity is tricky, navigating different perspectives that people have? Yeah, go for it.
So our group kind of talked a little bit about complexity, but more towards the direction of changing people's experiences by introducing play, joy, art, helping them reclaim hobbies, and maybe even doing new hobbies. If they couldn't paint, build with blocks, or doing something different, and incorporating elements from their hobbies, sports, and their life into the therapy, so that way they can find that joy again, even though the pain has taken that away from them.
Nice, nice. Any others want to share? This is also an opportunity to ask any questions about either of our talks, if you have specific questions for us. If not, we'd love to hear about, some summary of some of the questions that you discussed. Yeah, go for it. Thank you.
Hi. So we were talking a little bit about everything, I think, and it sort of just ended up us talking about really pain as a lived experience and how do you measure suffering with that, right? So we did sort of discuss the possibility of maybe learning more about Dr. Schubiner's work with emotional expression, or maybe even Alan Gordon's work with pain reprocessing therapy as something here in this summit.
Good stuff. Did you talk about, sorry, I don't have to put you on the spot if you don't want to answer this, but did you talk about navigating maybe conflicting perspectives, different perspectives, and how you navigate that? Yeah, go for it, yeah.
That's all right. I started this off with what is my philosophy of pain is that it sucks. And they wanted me to expound on that. And I said, no, it's all encompassing. It's all encompassing. It sucks. And we did explore many different areas of how do we teach massage therapists that stress can be a good thing because that's what's motivating you to get out of bed and go do something. So stress isn't negative, so then maybe pain isn't negative sometimes. And your pain isn't fitting into my cookbook recipe of how I've been trained to deal with people, now what do I do? And being able to think outside of that box. And then we had the thrill of having tomorrow's presenter at our table, just guiding us and teaching us and enlightening us hugely, which you can all hear tomorrow.
Lovely segue. Yes, please. We've got an online.
We got an online question here from Heidi Sue Roth. She asks, what do you see as the relationship between the significant financial investment in biological pain research, such as the TRP receptors, and enactivism?
Very, very specific question. I think one way I always kind of think about it is as a holistic or comprehensive heuristic where we can kind of zoom in and zoom out at different levels. So I think in no way am I downplaying the importance of basic science or neuroimaging. That stuff's important, but I think we also need to contextualize it and consider the other broader factors that I mentioned, but also mentioned earlier this morning about culture. So it's not like we have to toss that stuff away, but maybe more contextualized approaches would be helpful. That said, you mentioned funding. Prominently, if you look at pain research, it's biomedically kind of funded work. The more funds that are shunted towards that, maybe less towards social sciences, humanities. So there can be issues there where there's established social interventions that we know are helpful, yet they're not getting funded, they're not getting further researched, so there are some limitations there. So maybe there could be a bit more balance if we're talking about it in that sense.
And I suppose something I would like to add is when thinking with and through philosophy or theory, it's sometimes helpful to ask, what does that particular perspective, philosophy, ontology, reality, interchangeable at the moment, what does it do? So I suppose we live in a world where biomedical research has saved lives and continues to save lives. So it doesn't make sense to kind of go, that's rubbish. But I suppose based on some of my data that I shared, it's the promise of biomedicine also makes it really difficult to think about pain through a different lens, because it's like that, I don't know if it was a GP or a physician said, we can fix hearts, why can't we sort this out? So I think the work on TRPV1 receptors and TRPM8 and, downward signaling and mRNA perhaps has promise, but maybe more is directed towards it because of the structures and systems that we are kind of all in. I would love it if someone told me there was a genetic marker that would zap pain, because it sucks, And while as you were speaking earlier, Stephanie, I think it's Stephanie, you said pain sucks, and maybe that's not the only perspective. So we know that there's a small contingent of people who really like pain, right? And do we hear about that? Yeah, right? So that is another perspective that perhaps we don't consider, and what does that do? So what does that perspective bring to the picture? Anyway, enough about me. Yeah. Was not a confession.
All right, so my group made me come up, so I'm not a big speaker. But so to me, this is very academic, and I work in academia, and I'm just curious to hear your perspective on how you see this, how it might fit in academia. And a conversation that we had earlier over some drinks is, I feel like we bring our students into, I'm in a physical therapy, bring our students into physical therapy schools, and we dehumanize them. They are more human before they come to school than after, and how, if bringing the enactivism approach to PT school or other schools, how you might see that fits.
Yeah, that's a great question. Yeah, I think a lot of the approaches that are already done and endorsed are already essentially advancing a lot of these ideas. So you think of like teaching on the therapeutic alliance, building a relationship, talking about the culture of pain. When that's built into curriculums, that's inherently essentially expressing this enactive approach. So I think of like my teaching, I do some teaching as well, and I think back to like starting in 2013 where I tried to talk about these things, and it wasn't that sexy. Like talking about the therapeutic alliance, people are like, I want to learn about biomechanics, I want to learn about ACL rehab. But I think there's been a lot more research, there's a lot more people getting this kind of like more kind of comprehensive, socially based, culturally based approaches out there. And I've noticed a slow shift in students. They're starting to question maybe some of the overly narrow approaches. They're getting more excited to learn. I'm not going to use the word soft skills. Michael, I think you hated on that. I'm not a fan either. People joke that like soft skills are the hard skills. But I think there is some truth to that. But yeah, I think there is a slow change, and it's just getting more and more folks kind of talking about this stuff and getting it more in the realm of academia. But yeah, it's certainly on the outskirts for now.
Yeah, and I think with the table at the back, we spoke a little bit about disruptive curriculum, right? We were saying some of us, depending on when you were trained, would have learned one particular skill set that might be completely either fully defunct or just doesn't fit into the current model. But there was this sense of some disruptive programs do exist where they are taking that first step and ripping it apart. And I have to say, I think where some of this change or movement is coming from is by creating and listening to people who have lived experience of pain. Because as soon as you listen to them, you may perhaps not spend 6 months on ultrasound training. You might say perhaps what we need here is some core skills that mean that people are not exposed to moral injury, etc., etc. So I think it's happening, but we don't yet know what the outcomes are. I feel like we should start a race like in Squid Games.
I'm really nervous talking in front of groups, but this has been really impactful. I think just the I don't feel like we can talk about pain without talking about pleasure, because they go hand in hand, and just the importance of non-sexual touch to our well-being. I'm a massage therapist. But I also like really geeking out about a lot of this. And recently, over the last year, I've been studying Betty Martin's Wheel of Consent. Does anybody know about her? Yeah, and so I've been doing this exercise in her book on giving and receiving called Waking Up the Hands. And because the hands have more nerve endings than the lips or the genitals. And so you sit with an object, and you sit back, not forward, so you're out of doing mode, and you're in receiving mode, and you feel objects. And it could be, something from nature. It could be like a pen. And you're not trying to name it, but you're really strengthening the afferent signals that we don't get a chance to experience very much. And over time, this practice for me, I feel it when I'm not doing it, almost like in the days that follow, like just these moments of joy where I'm like noticing something that didn't happen before I was doing that. And so I just wanted to share, my mom is decreasing off of pain medication right now, and doing this practice, I'm just noticing she's a little more receptive to new ideas, where she used to just be like, really heels dug in. And so, and I'm also curious about research. So if anyone here, I have an idea for a research study I'd love to do, and so I know nothing about research. So if you do, hit me up. Michelle Pearson.
Thanks, Michelle, and thank you for stepping up to the mic. For those of you online, there's a microphone in the middle of the room, and thank you for being brave and sharing that. And I think one of the things that we discussed in our preparation was, I suppose, similar to what Gillette was talking about, is whose knowledge is prioritized, and what do we end up losing when we don't listen to different voices that are divergent or that are different from the norm, thinking about power and injustice. And I think research that speaks to all of that can only add to what we're doing, rather than, I know what will get funded, so I'm going to only do that kind of research. Perhaps there's space for, well, I have my big funding pot, perhaps I can squirrel away a little side study to start off with, et cetera, et cetera. But
it's Friday night. You're probably sick of talking about theory. Is there anybody else, though? Final call. Anybody want to share? Yeah, let's go party.
Let's give them a round of applause. Alrighty, so it would not offend me at all if you gathered your things while I gave the end of the day announcements. Number one, please do not eat your chocolate. Bring it back tomorrow. Okay? Just don't lose it, don't forget it, don't eat it, bring it back tomorrow. All right, number two, what was that?
Is this all part of the whole idea that pain sucks?
It's
of us waiting another day for that piece of chocolate?
Some would say that's savoring and part of pleasure.
Huh?
Anticipation.
Sadism is...
It's anticipation.
Sadism?
Maybe. I guess it depends on how you define it. That's a whole nother philosophical discussion. Number two, there's tickets in your Padfolio. That is for a drawing that will happen, I think, tomorrow. But just pay attention to the announcements, because you do need to be present to win. If you're outside sunning yourself or coloring, if you're not in the room. The quote is you would be SOL. So, okay. If you enjoyed the talks today, you can get access to the recordings for $75. They will not be available for purchase after March 10th, so get them on the website. Okay, if you have not yet signed up for the party tonight, you can show up tonight at 7, bring $75 with you to get in. Yes, ma'am.
So to clarify, today's talks...
All the talks will be $75 for the...
So the entire weekend...
Correct.
Of talks is $75. And then at the end of the year, they're free on the YouTube channel. Does that include today's talks?
That would be
To understand delayed gratification.
That would be probably a great question for one of our volunteers. I do not know the answer for that.
Okay.
But it's $75. It's still a heck of a deal. And I do not know if they will be posted at the end of the year. Finally, so the hot tubs here have a long, distinguished history of where many of the best discussions actually take place. I feel like I'm in like the previous generation of this, but for the new generation, if you're interested, Rajam has arranged with the Dana to keep the hot tubs open till 12 so that you do not need to get kicked out or chased by security. So thanks to Rajam for doing that for us. Again, open midnight all weekend long. So please go, have a great time. We'll see some of you at 7. Oh, tomorrow starts at 9:30. Okay, so again, hot tubs open till 12, talks start at 9:30.